Welcome. This is episode 7 of When Is It About the Patient? I'm Christine McMahon. I have my co-host Carrie Burmeister, and today we have a very special guest, Sue Serrato, and she's a physical therapist, and we're going to talk to her about different things with physical therapy that patients hopefully should know before they go to physical therapy to help them. So we'll start this out with Sue. What are some common diagnoses that require physical therapy?
Yeah, sure. Thanks, Chris. Typically, people associate physical therapy with like orthopedic or neurological diagnoses. Orthopedic would be like a fracture or a total hip. Neurological could be stroke, head injuries, Parkinson's disease, and whatnot. We see folks with cancer, but the reality of it is we can work with any diagnosis or injury that results in a functional decline for the patient that has potential for improvement or recovery.
Hey Sue,
Good
so
answer.
what do you look for? What does a therapist look for when they do the first initial evaluation on a patient that's coming for
Yeah,
therapy?
so yes. So we do basically a full objective neuromuscular functional assessment along with an assessment of the symptoms and the causes for whatever the decline in function is. So as part of that, we're going to look at range of motion, strength, pain, movement deficits or patterns. We also are going to use outcome tools, which I know we're going to talk about a little later. But then we also, really work hard with the patient to determine, what are their personal goals and objectives from coming to therapy.
What are the various types of therapy that fall under physical therapy? I know that in the last probably 10, 15 years, physical therapy has expanded somewhat to include other things.
Yes, yes. So what's really changed, and I graduated in '87, so all this has happened, and I've watched it happen, which is beautiful. Um, Therapy has become more specialty focused. It has gone from being a bachelor's degree, which is what I have in physical therapy, to being a doctoral degree. So the various types of therapy are have changed from being pretty much most of us were general practitioners when I graduated in the '80s where there's a lot more specialty areas, and those are not dissimilar from how physicians practice. Um, our specialty areas typically have certifications associated with them. The American Board of Physical Therapy has 10 different currently certifications you can get through the APTA, which is the American Physical Therapy Association. And those are like geriatrics, neurology, oncology, sports, orthopedics, and then there's several more. Also, there's other ways to attain a specialty through other professional organizations, and those fall more around techniques. And those are like manual therapy, myofascial release, dry needling, certified brain injury specialist, vestibular lymphedema. So I think the biggest thing from what types of therapy fall under, it's very much driven by what's the physician's specialty to some degree, or if they're a general practitioner. And again, what are the patient needs? So yeah, so it's not like specific types of therapy, it's what does the patient need?
I have a quick follow-up to that. So
Sure.
just just based on my own experience, when you say there's like specialty therapy, so not every physical therapy location is going to do every specialty, correct?
Yeah, and again, most therapists are trained to be general practitioners. But if you have a lymphedema, which is this edematous arms and legs, typically it happens after breast cancer surgery. A general practitioner should not be doing the wrapping and whatnot. Like it's a very specialized technique to do a lymphedema treatment. Now, a general practitioner can work with orthopedic and sports and strokes and whatnot, but some people choose to specialize in that. So I would encourage you when you're seeking out care that you think along those lines. What is it that I really need? And are there specialists in the area near me?
Hey, Sue, one of the things that I think is newer, and maybe it's my age that I'm learning about is the pelvic floor.
Oh yeah, yeah, for sure. Yeah, definitely. Hey, if you need it, there's nothing like a good pelvic health specialist to get your life back. Pelvic health can revolve around a lot of things. I mean, most people probably think more of incontinence, and incontinence can be an issue for men and women, and it can be urinary and it can be fecal incontinence too. In addition to that, there's a lot with pelvic pain syndrome. And yes, there are specialists in that area that can definitely help you. If you need a pelvic health specialist, I would seek out a pelvic health specialist.
Okay. How are the patient's goals determined when, like, after you do your initial evaluation?
The patient goals should be 100% patient or caregiver driven whenever possible. And then what the therapist has to do is, along with getting patient input on their personal goals, then the therapist has to make sure the goals have a primary functional component. That means our goals can't be just decrease pain or just increase endurance and whatnot. They really have to have a functional component, such as I want to go back to work. I want to play golf. I want to be able to get out of bed to my chair next to my bed by myself. Those are functional goals.
Are those, just a follow up to that, so those functional goals, are those required for insurance billing?
Yes, very much so. So yes, so CMS or Medicare tends to pretty much drive insurance approval patterns. Not always, but a heavy influence. And there has to be a functional component to the goals. There has to be a functional component to the overall therapy plan of care. And then we also have to be able to do functional outcome measures, which I know that's another question coming up. But yeah, it's very much insurance driven. And when I say that, most insurances follow Medicare guidelines. But yeah, it's a requirement that first of all, that the patient needs the skills of a physical therapist, and that there will be objective measurable improvement of at least one functional component.
So for the average patient, how long would they plan on being at a session?
Okay, so this will vary completely depending on the session you are operating in. If you can be in the hospital, you can be in an outpatient clinic, you could receive therapy services through home health, you can receive therapy services on inpatient rehab or in a skilled nursing facility. So those settings are very variable. But in general, a typical therapy session probably lasts somewhere between 30 and 60 minutes, depending on, again, the setting and the acuity of the patient, how sick they are, and the patient's tolerance for the session.
And then about how many sessions is typical, I guess maybe before you reevaluate or you discharge the patient as completing the goals that they needed?
Yeah, good question. So again, that's going to vary on the setting as well. And just to kind of give you the extremes of volumes, like in an inpatient rehab, the patient is going to receive 3 hours of therapy a day, at least 5 days a week. And that's usually for about 2 weeks. If it's an outpatient clinic, they will probably receive 1 to 3 visits a week for 1 to 8 or more weeks. And when you asked about reassess or discharge, a therapist is reassessing their patients every time they see them. They're not calling it a full-blown reassessment just because, again, Medicare guidelines doesn't allow us to bill for a reassessment unless something very specific changed. But we still reassess every visit. Just, we're reassessing motion, pain, functional patterns and whatnot. But typically, again, there's a mini reassessment done every visit just because it's part of what we do. But if we speak to just outpatient, typically a full reassessment is done at least once every 30 days. Or if there's something that changed with the patient, let's say they fell at home in between visits, then we would reassess them. Or they came in with a whole nother set of, maybe their blood pressure is spiking and they're fatigued and short of breath. Well, obviously that's going to result in reassessment and possibly a 911 call. So, yeah, it's very driven.
Okay, does physical therapy, does it require a prior auth from insurance? And does the insurance company dictate the number of visits?
Yes. Okay. So I'm going to answer this from an outpatient perspective and an inpatient rehab perspective. Well, acute care too. So if you're on the hospital side, if you're in an acute care hospital, therapy is just automatically provided based on the patient needs. Because in that setting, most payments are based on PPS or CMGs or whatnot, or DRGs, excuse me. So if hospital, you're going to get what you need based on the interdisciplinary team's input on the need for therapy, and then therapy gets in there. They provide patient needs. If you're looking at outpatient, typically, again, if you're following Medicare guidelines, you need the physician to sign the plan of care that the therapist generates from the assessment session within 30 days of that initial eval. That's kind of more of a pain in the butt paperwork thing that we deal with because it doesn't seem to really accomplish much just to get that signature. So we're actually seeing some activity on Capitol Hill with possibly changing that. But most folks, if they require pre-auth, it varies by insurance, but some do require pre-auth, and then some require the signature on the plan of care within 30 days, which kind of works as a pseudo pre-auth or post-auth.
Just with that, just a follow-up, do you feel that the insurance companies usually allow enough visits to get the patients where they need to go?
So I'll answer that for outpatient, and then I'll get on a soapbox about inpatient rehab. If that's okay. Okay, so most payers in the outpatient sector, as long as the patient is demonstrating objective and measurable functional improvements, will approve additional visits when needed. But if a patient is plateauing, meaning they're not getting any better, we're required by Medicare to not see you anymore. So when that happens, we really are beefing up what's the home program, trying, which we do anyways. But when you're plateauing, you're not benefiting from our skills anymore. So it's not, doesn't make sense, and it's would not be right to continue to see you and bill for it. But yeah, so typically, as long as you're improving in the outpatient sector, for the most part, excuse me, additional visits typically would be approved. Now I'm going to get on my soapbox about inpatient rehab. We have in the last few years, so let me back up. So most patients on inpatient rehab typically come from an acute care hospital. They have suffered some type of injury, disease, or whatnot that put them in the hospital. And then now they have fairly severe functional deficits that can be best addressed in an inpatient rehab setting, where they will benefit from and tolerate an intensive rehab plan of care, and that is the 3 hours a day, at least 5 days a week. So prior to a few years ago, we could admit folks to inpatient rehab presumptively. And that meant we had our process for determining if a patient met all of the Medicare criteria for an inpatient rehab stay. And then we just admitted them. And then CMS would kind of do an audit of charts periodically to make sure you're following CMS criteria for inpatient rehab and whatnot. So this is before Medicare Advantage plans. So before the MAPS started, we really had just kind of like a seamless transition from hospital to inpatient rehab. It was to the patient's benefit. There was no gaps in care. They weren't sitting in the hospital too long. We could get them into the inpatient rehab and get them home as soon as possible for a safe discharge home. Now what's happening is, since Medicare Advantage plans are very much involved in the decision-making process for whether a patient is appropriate for inpatient rehab, and they're supposed to be following Medicare guidelines. So Medicare has told us for years, you're doing a good job following our guidelines. Now these Medicare Advantage plans are kind of developing their own interpretation of Medicare guidelines, and they're not supposed to be doing that, but it's happening. And there's a lot of again, movement on Capitol Hill to try and get these Medicare Advantage plans to stop creating their own interpretation of Medicare criteria and follow the Medicare criteria. And just to give you kind of a idea of how big of a problem this is, and I know I will not mention any specific insurance companies that will get us all in trouble. So last year, Medicare did a targeted probe in education of charts. So they randomly last year asked us for like 40 patient names, and they dove into those charts. They did not deny any of our charts. They said we were good. And then also, so basically, if it's CMS, if a patient has straight Medicare, they're saying we're good, we're following guidelines. They have no concerns about the patients we're admitting. We have two big Medicare Advantage plans that have an 85% denial rate for inpatient rehab.
We're very familiar with those plans.
So, and they're supposed to be following the same rules. So I'm part of the American Medical Rehab Providers Association, which is a professional organization that's really focusing on Medicare Advantage plans and IRF denials and everything that goes along with that. So luckily, CMS has pushed out some recently statements or letters or whatever. They push stuff out like that. And that they're saying we're going to start looking at this. We're going to be doing a deeper crackdown. These plans need to be following Medicare guidelines, and they can develop their own process. If they're denying a case, they have to be more specific, and instead of just saying lacks medical necessity, because that's all they say. Right. They have to give us the specific of what's lacking. What else? They're going to have to start being more transparent on their denial rates, but I don't think it's been posted how or what that means. But like, we know we have Medicare Advantage plans that are at 85% denial rate. Then we have some that are at a 25%. That's probably the biggest one. And then we have the bottom 3 or 4 in straight Medicare is part of those, where there's a 0% denial rate. So that's my MAP soapbox.
And that's okay, because that's coming under a lot of scrutiny. And, now that I'm of that age where Medicare is something that I'm paying attention to, I can tell you, I just wrote a little dissertation they send you things, AARP sends you things, and respond and give us your thoughts on this. And now that I don't work, I have time to sit down and give them my thoughts. Yeah. And I did. And that was something that I talked about. I said, you have all these Medicare Advantage plans out there, and you think that they're doing a better job of making sure the patient is taken care of, when actually what they're doing is denying and delaying care. And in the meantime, many providers still continue to give that care because the patient obviously needs it. And at the end of the day, then they don't get paid, and it's very unfair, and they can't bill the patient.
Right.
And so you end up eating that cost. And I said, this doesn't work. And I didn't go into it, but really, I know just from my own experience, the big problem is that when you're appealing something to people on the other end, you're appealing to people that don't know anything about your specialty.
Yep, exactly.
And that is a problem,
It
you
is
know,
very much so.
and their peer reviews aren't peer reviews.
You're absolutely
Yeah.
right.
And that's problematic. And I understand that it might take some extra work to get people from every modality involved for insurance companies, but that is the only way to make it accurate.
Right.
And
Yeah.
You're right. And actually, I think that's another uh, update that CMS is putting, or Medicare is putting on the Medicare Advantage plans, is that the folks that are doing their appeals and peer-to-peer have to receive specialized education and training in that field. Now, nobody defined what that is, but it just, again, is showing that Medicare is aware of it and is just starting to address it.
And I think just for the common person, a peer-to-peer is when a physician
Oh, yes.
from the insurance company discusses your case with the physician in charge of your case, whether it's your surgeon or your primary care or
Right.
the hospitalist that's seeing you within the hospital. And they try to determine if the care was appropriate. And what we're seeing right now is a lot of times those physicians hired by the insurance companies aren't in the same specialty and may not fully understand the care that the physician in charge of the case is trying to get for their patient. So,
Well said. Thanks, Carrie.
thanks for clarifying that, Carrie.
Yeah.
I think we're in the business so long sometimes.
We get, yeah. So the other thing they're doing, which is wrong, is we may recommend inpatient rehab setting, and then they'll tell us no, and in the same breath say something like, but if you send them to SNF, which is a skilled nursing facility, we'll approve it right now. So they're almost trying to incentivize the acute care hospitals to send patients to a lower level of care when it's not what the patient needs.
They're just trying to save money.
Right.
So I guess that brings up a question, Sue. What's the difference between an inpatient rehab and a SNF?
Okay. So thank you. That's a good question. Inpatient rehab is a much more specialized, intensive rehab stay. When you go to inpatient rehab, you're going to have a physician laying eyes on you at least 3 days a week. Usually it's 7 days a week, depending on what location you choose. And then you have a whole interdisciplinary team looking at you. It's your case manager, your frontline nurse, your physical occupational speech therapy, if you need speech therapy. Everybody's got eyes on you doing their full-blown assessment. And then at least once a week, they're getting back together as a team to decide what are the best next steps for you as a patient. Again, it's intensive, where it's typically more like 3 hours of therapy, 5+ days a week. Lots of family involvement as much as possible in that process. And typically 80% of our patients go home from inpatient rehab. Skilled nursing is kind of more like a nursing home. So inpatient rehab is not a nursing home. Skilled nursing facility is a nursing home that does provide therapy. Now, typically in that setting, you may receive 60 to 90 minutes of therapy a day. So it's much less intensive. The physician requirement, I think, and I apologize to any SNF folks on the call, I think the SNF requirement is 1 visit a week for the doc. Don't quote me on that. And then I don't readily have a SNF discharge home rate, but I do know it's much less than 80%. So the big difference, and of course I'm in the inpatient rehab world, your chances are much better to go home. Your chances are much better to be a higher level of functioning when you're discharged from our facility, and that you're going to be able to do more for yourself if we are able, to get hands on you. So.
And my guess for the insurance company is it costs them more to put a person in or to pay for the treatment in an inpatient rehab versus a SNF, since it is so much more intensive, and that's why they're trying to
it is
almost
for
downgrade that to the SNF. I don't know.
Right. So the cost, of course, it is going to cost more, but you really got to look at readmission rates,
Right.
and it seems like we haven't looked at, with the pandemic showing its nasty little face. I think we kind of got away from really assessing cost avoidance strategies. So, and I think that's starting to come back into these discussions. So,
Well, I think we need better, Sue, and you can correct me if I'm wrong, but from where I'm sitting, I think we need better data on long-term outcomes for the patient. Like, okay, if I leave your facility and I'm at 80%, and the chances of a readmission or ending up back in therapy are very low versus you ship me to a skilled nursing facility and they're going to send me home and I'm at 50%.
Yeah. So I think that was kind of our starting to be our focus pre-pandemic, and now it's kind of coming back, and I think Medicare is actually making that part of what they're expecting the Medicare Advantage plans to do is to be very transparent about performance metrics, and I do believe readmissions and whatnot will be part of that. I know Medicare looks at that, and Carrie, help me. What if you're pulling Medicare data from a bunch of discharged patients? There's a word for that. From cost, does that make some like Medicare can do some of that, but I don't.
Yeah, they do. They send out different reports, and some of them, I know one that we used to use was called a Pepper report. So they would send out they do gather that data and get that information out to providers, and it's publicly out there for others to view.
And it's typically like 18 months behind, though. You know what I mean? So it's not like real-time stuff that you can, implement change with. But Chris, your question is, shouldn't we be looking at it? Yes, absolutely. And I think we're heading down that path again as a country. Now, there may be other health systems that are doing it, because I do know, but I guess I'll stop there.
It is hard to gather the data, even with all the electronic medical records and stuff like that. This is just a side note, the report writing capabilities of actually extracting this data and compiling it into meaningful analysis sometimes is very difficult. So it's all in there. It's just trying to get it out and aggregate it in a way.
Yes. So what I think it's fine that I say this. So there are huge systems in the country, like, and they typically have what they're calling a population health department, where they got executives, data analysts, and whatnot, all doing what Carrie just described. So, but I think we're just going to see a lot more of that in the near future.
Yep. It's better for everyone.
Oh my gosh, yes. We don't want to do it if it doesn't make sense. Right. We want to do what's best for the patient. So then again, it's got to make financial sense too. And that's where the data can help us. But typically what makes the most financial sense should mirror what's best for the patient. So, you
would think
that's where we're going.
Yeah. Yes.
So all that being said, at the end of the day, how does a physical therapist actually measure improvements in a patient?
Okay. So we do a lot with outcome measures, and that's a tool to assess a patient's current status. And typically we'll do those at admission, maybe once or twice during the care timeline, and then again at discharge. Again, the outcome tools we use are evidence-based, research-driven, and there's basically four main types of outcome tools. One would be a self-reported outcome tool, where you typically have a patient fill out a questionnaire that's kind of typically done to gauge like pain patterns and whatnot. Then there's performance-based outcome tools where that are specifically an assessment of a movement or a task and the time it takes to complete it. And if there's any normal or abnormal body mechanics going on with that. There's observer reported tools, which is basically the clinician just observes the patient, or you interview a caregiver who regularly observes the patient on a daily basis and asks specific questions, and then clinician reported measurement tools. Again, I can't stress how much those are very much evidence-based driven. And then what else is nice about evidence-based is there's with these tools and with our doctoral therapist, there's so much more focus again on what is proven in the research to make this patient better based on their functional deficits, based on their diagnosis and whatnot. And it's just all linked together.
I know we kind of talked about it, but is there anything else that has advanced in physical therapy in the past 5 to 10 years? We kind of touched on most of it, I think, at the beginning of the call, but
yeah, I think that, it's to just kind of wrap that piece up again. It's gone from a bachelor's to a doctorate, and it's progressed from kind of being a more technical profession to a more in-depth analytical assessment and treatment with a heavy emphasis on patient education and outcomes. And it's all evidence-based driven.
This is, I'm going in a different direction here, but
That's fine.
patients, what's some good tools that patients could take away that they could do themselves to keep them out of your office?
So, general health and wellness. You know what I mean? So, in lifestyle changes to promote general health and wellness. Again, we see orthopedics. Unfortunately, there's a lot of athletes out there. And again, that's a whole nother sector with bracing and all kinds of stuff. But athletes tend to get hurt. They tend to have orthopedic injuries. So you're not going to stop playing your sport, but you're going to probably, better prepare your body so it doesn't get injured, which, is weight training and tons of other exercise activities. If you want to avoid having a stroke, you need to follow, there's a lot out there about stroke risk factors, smoking, high cholesterol, I think alcohol consumption, stress, and whatnot. You would manage those lifestyle changes to prevent a stroke. So it's kind of, I would say, if you're worried about something, diabetes, manage diabetes. But just, staying in a generally fit state, make sure your movement patterns, your body mechanics are very appropriate for the activities you're engaging in. Eat right, plenty of fluids. It's what anybody's going to tell you really to stay healthy.
Walk. Just walk.
Yeah, just walk. Yep, walk.
Carrie and I learned that.
Yeah,
It's really helpful.
Yep.
Do you guys walk together, or what did?
Yeah, we can.
We haven't, the weather's been it's getting better, but the weather can be a deterrent for outdoor walking. But yeah, we walked every day, like 1.5 miles twice a day. And then we continued to walk after we weren't working together any longer. But it's so good for you. It's good for your mental health, and it helps you manage your stress.
Exactly. And yeah, I know for myself, I'm always in such a much better place mentally when I'm doing regular exercises, and it's proven. I mean, it's just crazy that we don't do it more.
Yeah. So what do you wish that a patient understood before they come to your office?
Typically, just when you come, and I think younger folks think this way, but if you're my age or older, when you go to therapy, it's not just what we do to you. It's not hot packs and massage. It's very old school. What we'd like the patient to understand is they're very much an active part of their recovery and must be committed to taking an active part in the process. You'll be given home exercises as part of your process. We're going to give you education on how to change bad postural positioning habits. Take it home and do it. And we may advise on lifestyle changes, which we just talked about how to keep you out of our clinic. So I think the biggest thing is it's not what we do to you, it's what we do with you, and more importantly, what you do for yourself when you leave the clinic.
This is just another random thought that entered my head. What surgery do you think is the hardest to rehab from?
Oh, wow. That's well, let me just speak from a total joint perspective.
Mm-hmm.
Okay. If you're looking at a hip and a knee, knees are usually harder than hips, but shoulder surgeries can just be a variety of shoulder surgeries can be harder to recover from. I don't know exactly why. I don't know if it's because there's not weight bearing going through the arm like the leg, but they just, and you got your neck attached to your shoulder, so you got stuff going on there. My gut would be, if you're thinking surgery, anything to the shoulder would be, for an elective surgery, would be probably harder to recover from.
Okay. Good to know.
Yeah.
Doesn't mean don't do it. Just means go in there prepared. Do you know what I mean? Like, make sure you're healthy, make sure the shoulder's strong and whatnot.
Are there any, and I know we asked what the patient should know, but what about the expectations? Do patients kind of have overzealous expectations of being fixed quicker than the process takes or anything like that? Do you run into that with patients?
Yeah, that does happen, but we try and make that part of the dialogue early on.
Okay.
But there is one other thing I wanted to mention, and it does kind of go along with patient expectations to some degree. There are a lot of recent developments in the area of pain science, so evidence to support pain science, that once a tissue heals after an injury, the site or cause of the injury is no longer generating pain signals. However, we all know, like, we've hurt something before, and months after the injury, we still have pain. So basically what I'm saying is where the site of the injury is healed, but we still have pain. And what research has found is that the brain and the nervous system has not let go of those pain patterns. And that's why you continue to have pain. I'm not saying this is a mental health issue. It's not that. It's just that the body is wired to keep telling you you have pain, and there's treatments to focus on that. So that's probably one of the most recent things that we've seen in our profession. That's super cool.
That's so interesting.
Isn't it? It's crazy. Yeah. It's crazy.
Yeah, that is interesting. Well,
so that's about all I had.
It's like losing a limb and you still have the arm pain.
Well, you know what? It's not. That's probably not dissimilar now that you say that. There is that component to it. I mean, if you lose a limb, you still have nerve endings in that extremity that play a part. But it's the whole pain science thing is just very cool. So if anybody has a friend that's in chronic pain and hasn't heard the term pain science or whatnot, research it, try and find a therapist that specializes in it, because it is another specialty technique of how you approach it and whatnot. So
We
Good
could
to
probably
know.
do a whole episode on that.
Yeah, you could. I would have to bring somebody else in. I'm not the expert, but yeah,
Good to know.
for sure.
Sue, this has been great.
Yeah.
I've learned a lot here. We really do appreciate it. We appreciate you taking the time to talk to us today and sharing your wisdom. And with that being said, I don't have any more questions. Do you, Carrie?
Nope. I
Okay.
think we covered it.
Yeah,
Thanks
thank
so
you.
much.
Thanks for having
Thanks.
me.